All right. So the topic given to me at the outset, thank you guys for inviting. Yeah, so the topic given to me was cardiomyopathy, that is HOCM. I think that's gone up somewhere. Okay. Is there a light at the end of the tunnel? Right. So I did picture a tunnel. I have put some light behind it, but let's see what comes off in hypertrophic cardiomyopathy. So, as we all know, hypertrophic cardiomyopathy is the most common inherited cardiac condition with the prevalence of almost 1 in 500 cases. Autosomal dominant is the mode of inheritance here, and it's the most common cause of sudden cardiac death in adolescent age group and young adults, with the highest risk being between 8 to 17 years of age. What do we already know about this disorder or disease? There are two types. Either you have a phenotypic HCM, which is where your echo pictures or echo findings give you a clue to the diagnosis. The other one is genetic and familial HCM, where almost 60 to 65% of them have a pathogenic or a likely pathogenic genetic variant. The most common, in fact, 60 to 70 of them are going to be the myosin binding protein C3. And a few of them, a bigger number, is also going to be a myosin heavy chain 7, with the rest of them all contributing to much lesser values. It's stuck. Yeah. So the non-familial HCMs that we come across, where we see the non-genetic variants, are mostly rasopathies like Noonans with lentigenes, that is your Leopard syndromes, glycogen storage disorders like Pompey's disease, and other mitochondrial disorders, and also Friedreich's ataxia and Dannon's. So these are the common non-familial HCMs that we come across as mitochondrial and metabolic disorders having hypertrophy of the ventricles. The clinical presentation can vary from just the child being completely asymptomatic and having a chance diagnosis, or a familial case, and hence you screen the family and then you pick up some hypertrophy, but the child has no symptoms whatsoever, and also range to some degrees, varying degrees of dyspnea on exertion due to the pathology that they have, like LVOTO, the MR, and the LV dysfunction that sets in later in the course of the disease. Syncope and pre-syncope are the most common presenting features that we see in the cardiomyopathy clinic with us. Heart failure, again in the later half of the disease, and strokes in adults. But the most dreaded symptom that or clinical presentation is going to be a sudden cardiac death. This is most challenging in adolescents because of the pubertal rapid growth spurt that occurs, and that increases the septal hypertrophy phenomenally once they reach that adolescent age. The diagnosis is based on ECG, where around 10% may still be normal when they are phenotypically still normal, but a genetic variant is positive. And what actually gives out the clue is a Q wave amplitude of more than 25% of the R waves and at least 2 leads in your 12 lead ECG. There is a scoring system that's come out from the Swedish group who works with hypertrophic cardiomyopathy, and the score of more or equal to 6 points with a sensitivity and specificity almost 85% based on these parameters that I have written down is going to be a very useful modality for risk stratification as well. So this is the ECG score. That's a proposed ECG score with a total scoring points of 14, of which 6 or more is going to be significant to predict or risk stratify for a sudden cardiac death. 2D echocardiography features, as we all know, is many, but the most important here is going to be your pattern of LV hypertrophy. Most commonly is asymmetrical LV hypertrophy, and that is called septal hypertrophy. That's ASH, which is about 65 to 70%. The others are going to be degree of LVH, which is going to be the red flag is going to come up when you have an LVPWD, that's a posterior wall in diastole of more than 11 millimeters, is when you have to start looking out to see whether and keep this child under radar for future evaluations. Okay, so LVOTO at rest and also after some exercise is going to give you a P gradient of more than 100 millimeters of Hg is significant. Mitral valve technically tends to be show a lot of abnormality in these cases, like with regurgitation, with systolic anterior motion that is increasing the LVOTO in these children, elongated mitral valve leaflets, and also submitral valve apparatus abnormalities. Look for the LV functions in them, like systolic and diastolic functions, which can get deranged a little later in your disease process. LV cavity and volume is again a very, very deciding factor for your treatment modalities. Like if you want to do a myectomy in them, so your volume of the LV is going to play an important role for the approach. LA size tells you actually what is going to happen, and the ones with LA diameters, which are very high, are at high increased risk for arrhythmias and also sudden cardiac death in these children. Coronary artery abnormalities with myocardial bridges are also seen. Always remember LVH is a progressive phenomena and warrants serial echocardiography evaluation. As I said, the red flag being 11 millimeters. So if you have an LVPWD of 11 millimeters, keep these kids in radar so that you're going to have a serial echocardiography evaluations. Stress echo or exercise, post-exercise echocardiography helps to identify the dynamic LVOTO on these children. And the clinical clues that you get is decreased or altered BP response. Normally after an exercise, your BP has to go up. Systolic BP more than 20 millimeters is a plus aside for them. But in these children, because of the LVOTO and the dynamicity, what you get is a decrease in your blood pressure or an altered response. So it doesn't go up. So that is again a clue that you have some abnormality there. Okay, presence of arrhythmias in your ECG or even on your, this thing tells you that stress echo is going to be an important modality. 24 Holter is very, very important, and this detects subclinical arrhythmias in these children, especially the ventricular fibrillations and tachycardias that you have. CPET is a newer modality which has come into use for these children. So 6-minute walk test or your stress echo. Generally, what we do is put them through a CPET or the cardiopulmonary exercise testing. That is immediately followed by BP recording to see for the BP response. And then also we do a 2D echo evaluation to see the dynamicity of the obstruction that comes up after this exercise test. Cardiac MRI is a new kid on the block, but a very, very useful modality for checking because it's got a very beautiful temporal resolution and a spatial resolution, and hence gives a structural and functional assessment along with ventricular volumes. And presence of myocardial fibrosis or scarring at these areas that we have, a very beautiful clue to predict arrhythmias as well as sudden cardiac death. So presence of scarring definitely increases the thing. So if you can see, yeah. So this is the scarring that you can see in these myocardium. This is a myocardium which is already hypertrophied, and there's a figure of 2.97. Most of the books tell you a figure of, if you have, this is 29 millimeters. So if you have 30 millimeters in adult, it's a super high risk. So for a child, and this is our patient, which we did on 4th of November, this just about a couple of weeks ago. So this, 4th of November, this kid is 11 and a half who comes to us with 2 episodes of syncope. And that's when we worked him up, and he turned out to be an HCM, not an HOCM, but an HCM. And we got a cardiac MRI done. And this is what the hypertrophy was. So he's going to be already in the high risk category for sudden cardiac death and arrhythmias, because your LV hypertrophy numbers are almost reaching 30 millimeters at 11 and a half years. And it's going to be progressive, especially in this adolescent age. So this is the same kid with a scar quantification. You can see 39% of the myocardial fibrosis is scarring in this child. And hence, he's again going to be on a high risk. Ideally, you are not supposed to be having any scar. Less than 6% is still the mild one, but anything beyond that is going to be significant. So genetic studies are very important. So this kid has also been asked for a genetic study. More than 60, as I said, have identifiable pathogenic genetic mutations. And if 2 heterozygous mutations are present in the same gene, the risk increases by 1.3-fold. And those with pathogenic mutations usually present at a much younger age, have more amount of LV hypertrophy, and there is an increased risk of rapid progression with adverse outcomes in these children. Once you get a genetic study done, the genetic study, once you've got a phenotypical HCM, you know he's an HCM. You do your CPET, you do your MRI, that again proves it. Getting a genetic test is important because you want to see if it's a familial HCM, and then you do something called a cascade testing. So when we do cascade testing or a Sanger sequencing, right, you have to do for the first degree relatives, everybody have to undergo a genetic test if you get an index case that is positive. Prediction of sudden cardiac death is a newer thing that has come up. So we have risk stratification of sudden cardiac death, which is the most dreaded complication here. A validated model. So our next speaker is Dr. Seema Mittal from SickKids Toronto. This study has been led by her. A validated model for sudden cardiac death risk prediction in the pediatric hypertrophic cardiomyopathy. This is by far the latest that's come published last year, 2021. And this is a beautiful study or a meta-analysis or actually a study that's carried out from entire North America, even ranging up to Brazil. And so they've taken multiple centers and they've got all the cases from there. So this is the best model, and it's validated for pediatric HCMs. This is called the primacy model. It's precision medicine for HCMs. It's almost 70 to 75% accurate in risk prediction for sudden cardiac death in pediatric HCMs. It's an international multicentric study which has taken into consideration 572 phenotypic cases. 2 risk models they've divided into 2 arms, one with only clinical symptoms and one with clinical symptoms positive, but also genetics positive. in cases of HCM. All the children included, that 572 cases that were included, were all less than 18 years of age. The primary outcome variable, what they looked at was time to a sudden cardiac death or a sudden cardiac event during a 5-year follow-up period from the time of enrollment into this study. An event, according to them, was defined as a resuscitated sudden cardiac arrest by whatever form. He's come into an arrest and you've resuscitated him, or you've aborted the sudden cardiac death because of a primary ICD implantation there, given by a shock given by your implanted ICD. The factors that they considered for going through this model and telling us a risk stratification is age, diagnosis, the family history, if they were present or absent, if there was a recent syncopal attacks within the 6 months to diagnosis, documented non-sustained arrhythmias on Holter monitoring, and the Z-scores on echocardiography of the various parameters. Genetic results were also taken into consideration. The observation that they had, the 5-year cumulative proportion of SCD events was 9.1%, out of which there were 14 cases of sudden cardiac death, 25 had a resuscitated arrest, 14 had an aborted SCD because of an appropriate shock that was given by the implanted ICD. The incidence of SCD was significantly higher in the pediatric population as compared to adult population. If there was a non-sustained VTAC on Holter monitoring, it increases the risk of a sudden cardiac death by 3-fold. If there was a history of syncope in this 5-year period, it goes up by 7-fold. And if the Z-scores of IVST and LVPW was more than 20, that absolute figure of 20 millimeters actually, then it increases your risk of sudden cardiac death. Older age diagnosis, positive genetic report just increases borderline by about 1.3. A family history of sudden cardiac death in a familial HCM actually had no association with increasing the death. An LVOT gradient, surprisingly of more than 100 millimeters of peak, had an inverse association. In fact, they had lesser deaths in children with increasing LVOTO, and they themselves are still working and kind of trying to reason why that is happening so. The limitation of this tool, it was only a retrospective data that they could gather of this 572 cases. So there is a survivor bias, there are missing data, all centers could not give them all the data that they had. And there was like non-uniformity of echocardiography skills because each center sent their echocardiography reports. So they could not kind of do it in one place and have the same person. Inter-observer differences were plenty. So that is one of the things. No cardiac MRI data was a part of this because this is a study that's retrospective. They didn't have so much of MRI facilities then. So they have not done CMRIs for more accurate dimensions. Omission of all the dysmorphic kids were there in the study. So they have not taken into consideration rasopathies and other dysmorphisms. And these ICD cases, even the test runs of ICD came into, taking this data. So there could be an overestimation of how many shocks have been given, which is inappropriate. So that is again an overestimation that's possible. All said and done, this is certainly the most useful decision-making tool to facilitate at least an primary preventable ICD in a patient after a proper discussion. So this is almost 75% accurate tool. So guidelines by the JACC in JACC or your American College of Cardiology in 2021 has come out with this hypertrophic cardiomyopathy in adolescent guidelines. It's imperative to make a 3-generation pedigree chart once you get a patient of HCM. There's no lower age limit for ECG and echo evaluation. Earlier, the studies used to say beyond 6 years, you have to keep them on follow-ups. Now it is not so. Once you have an index case, there is no lower. Even if you have an infant coming to you, you have to keep them on your follow-up and you have to do an ECG and echo. Screening of first-degree relatives of a proband is very important. Definitive echo diagnosis always has to be correlated with Z-scores and not absolute values, especially in pediatrics is what they say. If it's only genotype positive, then a yearly surveillance of this patient is mandatory. A genetic test has to be carried out in all family members for the confirmation of the diagnosis. A Sanger sequencing is carried out. If a phenotype is positive, then you have to do a CPET or a cardiopulmonary exercise testing, which is followed by an echo evaluation and Holter monitoring, again on a yearly basis. ICD implantation must always be a joint decision. It's a shared decision with the family, with the patient, because these patients are usually older, and weighing the risk factors. So you have risk factors. So American recommendation is to have at least one risk factor with a family history, whereas the European recommendation or the ESC recommendations, at least 2 risk factors out of these to sit down and have a discussion and have a ICD implantation in these children. Exercise restrictions, earlier was said that no competitive sports, no hardcore sports, but now it has to be tailored to individual cases with allowance of mild to moderate exercise to improve the aerobic capacity in these cases. So you don't completely nullify your exercise. Treatment, as we all know, comes under these 5 limbs: lifestyle or exercise recommendations, pharmacotherapy with beta blockers, and calcium channel blockers with the other drugs, septal reduction therapy like myectomy and alcohol ablation, and implantable cardioverter defibrillator, and finally the heart transplantation. For want of time, let me just go to what is commonly used and what are the recommendations now. It's beta blockers are the mainstay pharmacotherapy in these children. Better is propranolol, metoprolol as compared to the other groups of beta blockers. You always have to start them with a high dose regime. This low dose regime of 1 milligram per kg per day doesn't work in them. They've even gone up to almost 15 to 20 milligram in certain cases. But at least 3 to 5 milligram per kg per day is your starting dose. Titration is then decided on your yearly surveillance on Holter and your CPET results. Calcium channel blockers more in older children, not much in pediatrics. ARBs are not shown to be helpful in pediatric cases of HCM. Desoperamide is an antiarrhythmic drug, but class 1 recommendation to as an adjunctive therapy actually to beta blockers. It helps to better your diastolic function, decreases the dynamic LVOTO, and decreases the risk of arrhythmias to a very, very significant effect. Dosage is 2 milligram per kg. And the other drugs that are used or in the armamentarium, which are commonly used in pediatrics, is amiodarone, spironolactone. Once you have a CMRI showing you fibrosis and scarring, this is one very good drug, which is an adjunct to your beta blocker. Beta blocker is your mainstay. Everything else just gets added to it. Septal reduction therapy, if you have a severe LVOTO or an LV dysfunction because of or a low cavity, very low cavity, LV, very small LV cavity, then septal reduction therapies are offered. It is always more prudent to do a surgical myectomy because it's less than almost 1% mortality in a trained center with clinical success rate of over 95%. So this is usually reserved for those with NYHA 3 and 4 not improving on maximum pharmacotherapy that you've given. Younger children, a modified Conos is a preferred method. Transapical myectomy in case of very, very small cavity and you really can't access through transaortic route. Alcohol septal ablation is used for it's not so useful because you may have to do it repeatedly in patients. And if LVOTO is more than 100, it's definitely not recommended. It's always better to go for a surgical myectomies. ICD, as I said, is always a joint decision. At least 2 risk factors while on pharmacotherapy is mandatory and should be sat down and again done in a very, very experienced center. Heart transplant is reserved for those who have LVEF for 50. Usually with HCM, you have a hypercontractile heart. So once you have an LVEF coming below 50, plus you have an NYHA or the child is symptomatic or the person is symptomatic, that is a kid that you put in for heart transplant. Otherwise, heart transplant in HCM is relatively not recommended. The only caveat here is those patients who are on the transplant waiting list, they have seen higher mortality rate happening with HCM patients rather than the ones which are more commonly put in for transplant like DCMs. LVADs is technically not possible because of a very small LV cavity size because of the hypertrophy. So in conclusion, there is, again, no magic pill. There is no miracle treatment. There's no panacea for preventing or a disease-modifying therapy because of the poor understanding of the pathobiology of this disease. Most recommendations and guidelines are retrospective, observational, just expert opinions that have been shared from all these trials and centers. A few randomized controlled trials are going on, but more in the adult population with HCMs and an older population with diltiazem, valsartan for stabilization of LVH. A new drug called mavacamten is under a phase 3 trial right now, which is a myosin inhibitor, which prevents the hypertrophy from occurring. So that is a promising drug, and it also decreases the NT-proBNP levels in them. Gene editing and gene replacement therapy by CRISPR and Cas9 are also happening now. For trials are going on in that. And until then, again, we are left with our 4 treatment modalities of cardiopulmonary rehab, that's exercise recommendations that we have, our pharmacotherapy modalities that we have, and also our myectomies and septal ablation therapy, and continued surveillance is what we need in these children. So we run a cardiomyopathy clinic in Wadia once a week, and we have an OPD of over 168. When I just left day before yesterday, I checked my papers, of which about 18 cases are the HCM cases. That is 11% of our total population who's coming to the registered with us. Age of diagnosis has been as low as 1.5 months. And again, being a tertiary referral care center, they're already referred in infancy, and they usually come to us with either a family history, a known sudden cardiac death, or if they are referred to an ICU, And then we see Pompey's and things. So we did just a thing. Adolescent cases are about 5 with us, out of which one is a kid of 14 years who wants to be a football player. His father's a football coach. And this kid has already come to us with 3 episodes of syncope. And the family is now discussing ICD implantation. Yeah, he was looking at that possibility in him. So out of these 18 cases, we have etiology in 11 of them. 3 are still awaiting their genetics and 4 have got genotype negative. So rasopathies were 4. There were 2 Noonans and one of Noonans with lentigenes, that's Leopard syndrome. Pompey's were 2. Gene positive HCMs were in 4, with 2 with already family members positive, elder sibling and father who was positive. Friedreich's ataxia case is 1. All these patients are on beta blockers. I have not yet started isopuramide on any of them, but a few of them are on beta blockers and on spironolactone when I've seen fibrosis on the CMRIs. So having said that, the child and adolescent with HCM, is there a light at the end of the tunnel? Yes, I think the jury is yet out and you guys can decide whether there is a light at the end of the tunnel, because according to me, they're just guidelines which have got set just last year. And now we have to have a long-term follow-up in these children to see how they behave and how many of them actually get an ICD implantation or anything more. So thank you. It always seems impossible until it's done. Thank you very much for a patient hearing. It's a very encouraging thing to have at least 12 of you in the audience. Thank you.